Welcome to this December 11th, 2023 webinar recording from California Department of Healthcare Services, facilitated by WestEd. In this video, all information conveyed visually is spoken by the presenters. Thus, this video's content is accessible for users who are blind or visually impaired.
Well, let's get started. Welcome, everyone. Thank you for joining. We're so glad you're here for today's workshop, an introduction to LEA BOP for small and or rural LEAs. And as a reminder, LEA BOP stands for Local Educational Agency Medi-Cal Billing Option Program. Next slide, please. We are going to start with some introductions. First, the staff from the Department of Healthcare Services, DHCS, and the LEA BOP operations team. When I get to your name, those of you, please feel free to wave so folks know who you are. So from DHCS, we have Sarah Burkowski and Lydia Outland. And then from the WestEd team, we have Jeremy Ford, myself, Lisa Eisenberg, Lisa Morris, Colleen Meacham, and Malachi McCormick. Next slide. This workshop is part of DHCS's effort to increase understanding about the LEA BOP and improve program participation among LEAs. The goals for today's workshop are for participants to, 1, understand the benefits of program participation for small and or rural LEAs. 2, to understand the basic design of the LEA BOP. And 3, understand some strategies that address the unique challenges facing small and or rural LEAs in the LEA BOP. Next slide. Here's our agenda for today. We will begin with an introduction to LEA BOP. We'll understand cost reimbursement, which is how the program runs for small and rural LEAs specifically. Then we'll cover some strategies for rural and or small LEAs in hopes of helping you all successfully participate in the program. Then we'll have time for questions and answers. And finally, we will close out today's session with some next steps you can take. We want to encourage you to use the chat field to submit questions throughout this workshop. We have individuals monitoring and noting the questions that are submitted via chat, and we'll either respond during today's training or in writing after today. We will also get to some of the questions you submitted when you registered for today's workshop. And we get this question a lot, but presentation slides and a recording will be posted on DHCS's website in the future, and participants of this workshop will be notified via email when they are available online. We are dropping a link now in the chat to where today's workshop will be posted once it's available. And it's also where you can find previous slides and recordings from previous workshops that we hosted with DHCS to explain about this program. Next slide. So this moves us into the content. We're going to be getting into the section where we'll provide an introduction to the LEA BOP. Next slide. So about LEA BOP, some key things to know about the LEA BOP are, 1, it's an optional program for LEAs to recoup some expenses for providing covered health services for students enrolled in Medi-Cal. And the second thing to know about the program is it's an ongoing funding stream. So this is not one-time funding or categorical grants. And it's important to note that this is probably pretty different types of funding than what your LEA is used to. For example, the Local Control Funding Formula and the federal Every Student Succeeds Act, or ESSA funds, are sort of like block grants of funds that LEAs can generally use flexibly to cover expenses, from libraries to books to teaching staff. And in comparison, LEA BOP is a billing and reimbursement program to generate funds for the costs your LEA incurs to deliver covered health services. Next slide. So some of the benefits, there are many benefits to participating in this program for LEAs, and we're going to cover some of those benefits today. First, the program as I mentioned in the previous slide, the program provides LEAs with an ongoing funding source for some of the school health services many of you are likely already providing to students. So this is not necessarily to add services. These are services you probably are already providing to students, and it's a way to generate reimbursement for those services. Additionally, due to a number of new one-time state and federal investments focused on student health and wellness, you may be adding services or building out staffing based on that one-time funding. And this program, LEA BOP, provides a way to help you sustain some of those investments after the one-time funding runs out. So again, this is ongoing funding for some health services. The second benefit of participating is because this is a cost reimbursement program, which we'll explain a little bit in a later slide. LEAs are reimbursed for the reasonable actual costs of providing allowable services to students on Medi-Cal. So I think it's helpful to think of this as a little bit like an example, like a travel reimbursement. So it's the difference between reimbursing someone for the actual price of their lunch while traveling within reason and with documentation like a receipt versus a per diem. Depending on where you're traveling, your lunch cost may be higher or lower than the per diem. And this program is like the first example, reimbursing you for the actual costs of your lunch. And then third, because this program is every year, not only does that help you with sustainable funding, you can kind of rely on the dollars that you're generating through program participation, your LEA can begin to include those sustainable funds generated as part of the LEA's overall budget. And building your infrastructure to participate now will provide operational efficiencies going forward. So example, you build out your electronic health record system or whatever system you use to collect documentation of services provided. And you don't have to do that every year. You can use that system on an ongoing basis for subsequent years. Next slide. So those are the benefits. And now we will get into a little bit of what does it mean? What does CPE mean? So LEA BOP is a CPE program, which stands for Certified Public Expenditure. It's helpful to understand what it means for LEA BOP to be a CPE because it impacts many of the compliance requirements for participation. So we're front-loading you a little bit with what's required, and then we'll get into some of the strategies to help you meet those requirements. So CPE is a mechanism for public entities, in this case, LEAs like you all, to certify that the funds spent on Medicaid services are eligible for federal matching funds. And because Medicaid is a state-federal partnership, states put up some money, federal government puts up the matching amount, LEA BOP has to have a way to certify that the funds used to draw down federal dollars meet certain requirements. So what does this mean for the program? So the program has to have a number of components to ensure that participating LEAs comply with the program. And this includes, one, a cost report for LEAs to certify their actual costs of providing services. Two, LEAs must also certify that they're using non-federal sources as the match for reimbursement through this program. So an example, your LEA uses ESSER funds to hire and cover the salary and benefit costs of a bunch of new school counselors. ESSER funds were those federal COVID recovery dollars that went out to schools. And those expenses, those school counselors that you hired with those ESSER dollars, because those use federal dollars, are not eligible for this program. So you can't get reimbursement for the services those school counselors are providing. So we'll give you a flip side example. Let's say your LEA uses the Student Behavioral Health Incentive Program dollars, or SBHIP dollars, to hire school counselors. Those dollars were state dollars, and so those expenses are eligible for reimbursement through this program. And then finally, program participation is subject to an annual audit to confirm that your LEA's final amount you will receive through the to confirm what your LEA will receive as a final amount through program participation. Next slide. So, with that previous slide in mind, with CPE as like the program requirements in mind, it's important to understand the payment cycle, which includes the funding mechanisms and timing for this program. The graphic on the slide is a simplified overview of how your LEA gets payment through participating in LEA BOP. So, step one first, LEAs deliver services through allowable practitioners employed or contracted with the LEA. Then LEAs submit interim claims to Medi-Cal for covered services. Then LEAs receive interim reimbursements for those allowable services throughout the school year. Then LEAs reconcile actual costs with those interim reimbursements through the cost report that is submitted 8 months after the end of the state fiscal year. After you submit that cost report, LEAs will receive an interim settlement 1 year after the submission of that cost report before it is audited, before it is finalized. Those actual costs that you put in your cost report are then audited to verify that they are allowable expenditures. And then the process concludes with a final audited payment within 18 months after the submission of the first submission of that cost report. So I know that that's a lot of information, but I really want you to take one key point away about this information that was presented in the slide. And it's really, really important to understand that funding through this program is a two-step process. That the interim reimbursements for services you receive throughout the school year are not final dollars, but they are there to provide your LEA with some funding throughout the year. And final dollars are based on actual costs submitted through the cost report. Next slide. So at this point, you're probably saying, well, what services are covered? So LEA BOP covers services for students in special education. It's in the dark blue column. Those are students with an individualized education plan, or IEP, and students with an individualized family service plan, or IFSP. You all should probably be familiar with those documents. LEA BOP also recently expanded to cover services for students without IEPs or IFSPs. And these services for general education students, the treatment services for general education students, must still be included in an individualized health and support plan, or IHSP. An IHSP is not the same thing as an IEP or IFSP. I'm sorry, I know that was a lot of alphabet soup. Some common names for an IHSP or this kind of care plan includes a nursing plan. So these are common names that you might be using in your LEA. You might be calling an IHSP a nursing plan, a 504 plan, or school health care plan. And the plan can have many names depending on your LEA. The IHSP can stand on its own or can be incorporated into other plans as well. And the important thing to note is that it's a plan of care and includes the same information as other care plans. It just doesn't, and a best practice here would be to look to your nursing office as they commonly develop plans for non-IEP students. This might sound like a different thing than what your LEA already has, but I think the point here to stress is that you probably have plans in place for the health services of students that aren't in special education. So this isn't a new thing that your LEA has to implement. Okay, so to the services covered. For both groups of students, services include assessments and treatment services and targeted case management. For students with IEPs or IFSPs, the program also covers specialized medical transportation. So some examples of covered assessments include psychological and speech language assessments. This category also includes recommended preventive pediatric healthcare as published by the American Academy of Pediatrics. Some screenings that fall under the AAP recommendations include vision and hearing screenings, which you might already be providing to students. And some examples of covered treatments are speech therapy, nursing services, and individual and group psychology and counseling services. The program even covers physical and occupational therapy. And then something that might be particularly relevant for small and rural LEAs is that services, when appropriate, can also be delivered via telehealth. And we'll be talking a little bit more later about telehealth as a modality for delivering services. So again, lots of information on the slide, lots of information that we're covering. But I think the thing that we are hoping you are thinking as we're talking through some examples of those covered services is, oh, my LEA provides those kinds of services to students already. So a lot of this you might already be delivering to students at your schools. Next slide. So those are covered services. The program also covers eligible practitioners. So certain practitioners, certain people in your school are eligible to provide those covered services. There's a full list of eligible practitioners listed in the program's provider manual, and we're dropping a link in the chat to where you can find the provider manual. But some common eligible practitioners that your LEA likely already employs or works with are, I'm going to name a few, credentialed speech language pathologists, credentialed school counselors, credentialed school psychologists, credentialed school social workers. There's also licensed marriage and family therapists, licensed registered nurses, licensed physical therapists, and licensed occupational therapists. So you're not meant to memorize all of those. And if you don't hear a type of practitioners, definitely check the provider manual, which will include a list of all eligible practitioners under this program. So 3 things to keep in mind, particularly for rural and or small LEAs, are the graphics on your slide are the 3 types of buckets for how you can deliver services through these eligible practitioners. So first, LEAs can directly employ eligible practitioners. So these practitioners are employees of your LEA. The second bucket is the LEA can also contract with other organizations that provide the eligible staff for covered services. For many rural or small LEAs, you may often contract with your county office of education or special education local plan area for these staff. And then finally, as I mentioned already, eligible practitioners may provide covered services via telehealth. So your LEA employed or contracted practitioners may be stationed at a central or district office delivering services via telehealth to surrounding school sites. And then again, we're still going to be covering a little bit more of the telehealth strategy a little bit later in this workshop. And with that, I'm going to pass it over to my colleague, Jeremy, who will walk us through the next slides.
Thank you, Lisa. Hello, everyone. I hope you're all doing well. Let's get into the real exciting parts, which is understanding cost reimbursement for small and rural LEAs. Next slide, please. So cost reimbursement. Let's talk a little around the basics behind the cost reimbursement for this program and how the math works. It's important to ensure that your business office personnel are included in conversations around preparing to participate in this program. This is only a very basic overview to introduce you to the process, and it's not meant to be a full cost reimbursement training. You're not alone here. DHCS provides complete trainings posted to the website for the cost reports. To go through what's on the slide, you start with total allowable cost of providing those previously mentioned covered services. Generally, this would be salaries, benefits of practitioners and any contracts of those practitioners. The number is then discounted by the FMAP, which stands for the Federal Medical Assistance Percentage, and it's usually 50%. Then your MER, which is your Medi-Cal eligibility ratio, and finally the DMSP, which stands for Direct Medical Services Percentage. And that's just the time obtained from the random moment time survey. We'll briefly cover each of these components over the next few slides, but the main takeaway here is that reimbursement will increase or decrease based on your cost and these other factors like FMAP, MER, and DMSP. Next slide, please. Total allowable cost. What does that mean? This includes salaries and benefits of staff. For example, a school nurse providing a covered service. This also includes contractor costs. For example, your LEA contracts with a speech and language contractor for $50,000 a year, and they send you a speech and language pathologist that provides covered services to students. This is an example of what might be included as contractor costs. Other support costs like supplies, including psychological test assessments, can also be included here. This is not an exhaustive list. Next slide, please. And again, the FMAP stands for Federal Medical Assistance Percentage, and the FMAP represents the percentage of costs that the federal government will cover. As mentioned before, this is typically 50%, but it did fluctuate during the public health emergency. Next slide, please. And then we get to MER, or the Medi-Cal eligibility ratio. This is the percentage of Medi-Cal enrolled students in your LEA. This will vary by LEA. The graphic on the slide shows different MERs for two different LEAs. For LEA A, the Medi-Cal enrolled students make up 90% of the total population. For LEA B, the ratio of Medi-Cal enrolled students is 50%. One thing your LEA can do to increase the MER is to help students and families enroll in Medi-Cal. And those enrollment activities are also covered and reimbursable through another program, which is the School-Based Medicaid Administrative Activities Program, or SMA. Again, DHCS is here to support you and provides you a few options to get this data. Once you enroll, you'll have access to a data use agreement and training on this topic. You may not know today what your MER is. However, a helpful, although imperfect, way to estimate is by looking at the percentage of students eligible for free and reduced price meals. Both MER and free and reduced price meals are based on income eligibility, which is why we suggest it as a proxy to estimate how many of the LEA students are low income. Next slide, please. I mentioned the Direct Medical Services Percentage, or DMSP, which is the time obtained from the Random Moment Time Survey. So what is RMTS? The Random Moment Time Survey, or RMTS, is a time study mechanism that California uses to determine the amount of time spent on activities throughout a participant's workday. Eligible practitioners will receive a notification to respond to a random moment, which captures what they are doing in that 1 minute of time. Those responses are then coded as either covered activities, which creates the DMSP, or not covered activities. The DMSP is simply the percentage of time spent on activities covered by LEA BOP. We did a training in October explaining some of the mechanisms of participating in RMTS. Those slides will be posted to the website soon, but we're dropping a link to the training webpage where they'll be posted in the future. In order to participate in RMTS, you will need to contract with your local educational consortium, or your LEC. And you're not alone in this process. Your LEC will guide you through the requirements and which staff to be included. There's a link in the chat for the contact information for your specific LEC. which is broken up by region. Examples of cost reimbursement. To make the math of the program more concrete for your LEA, we're going to walk you through two examples of common costs. Let's say your LEA employee costs are $200,000 for 2 employed practitioners. This would include salaries and benefits, for example. You would take the total number of 200,000 and then multiply it by 50% for the FMAP. Remember, we discussed that on a previous slide. Then again, this number is the federal share, which is half. Then you multiply it by 65%, which would be the Medi-Cal ratio. This is just an example. Your LEA's actual MER will likely vary. Then finally, because these are employees who are in the RMTS and do the random moment survey, you multiply by your region's DMSP at 49%, which will also vary by region and year. This is all just an example. That math works out to the total allowable cost of $31,850. So what you can do with these examples is plug in your numbers or your estimate and see what the input and output would be. The other example you see on the slide has to do with contractors, which may be how a smaller LEA can provide services when they're unable to employ staff. This might also result in a total smaller cost, in our example, $60,000. You take that number and run through the same equation of FMAP times Medi-Cal ratio, but when you get to the DMSP, you do not multiply by that number, and we have it crossed out on the slide. In direct contrast to employed practitioners, contractors are not included in RMTS. They are not part of the TSP list, and they do not respond to random moments. So the total allowable cost in this example is $19,500, which is larger as a percentage. This is just an example that might fit your smaller LEA, but there are a lot of factors like indirect cost rate, changes in the FMAP, annual variations in the Medi-Cal ratio or the DMSP, and they're not accounted for in this example. Total reimbursement is always pending certification, audits, and final settlement. No one can tell a small or rural LEA if this program, if the reimbursement generated through this program is worth the administrative cost, but you can use the math here on this slide to discuss the possibilities and get a general idea of what you might be able to bill. We'll cover some strategies that can also reduce the administrative cost in the next section. Okay, strategies for rural and or small LEAs. Next slide, please. To address workforce issues, you can utilize telehealth as a modality for delivering covered services. You may already be using telehealth or looking to expand those services. We're going to provide you a few examples of how this could look in various settings. Example number 1, LEA employed staff at a district or central office. These would be your employees working at a central location, like the district office, providing telehealth to students at the various school sites. This may be a strategy if your schools are spread out over a large geographical area. Example number 2, contract with a telehealth provider. This would be a third-party company that often provides the technology, like the tablets and the computers, and the staff to complete the services with the students. Example number 3, a hybrid model, where an eligible practitioner is delivering some services in person and some via telehealth. This might be similar to example number 1, but once a week or every other week, the telehealth services are supplemented with some in-person treatment. An example of that I've seen is that individual speech therapy is done over telehealth, but then group is done in person. These are just examples and options. All this is to say, if an eligible practitioner is providing covered services via telehealth, those costs are still covered. For the purposes of billing, it doesn't matter whether those services are delivered face-to-face or telehealth. Excuse me. And we're going to put a link to the provider manual, the section that covers telehealth for more information. Next slide, please. The goal of consortium is to reduce a consortium The goal is to reduce the administrative burden for LEAs. The details around how you'll set it up will be a decision among the member LEAs, but a few things are constant. The consortium will submit a single CRCS, which is the cost report for this program. They will bill under a single NPI, which is the National Provider Identification Number, and how Medi-Cal identifies you. And there will need to be a contract or MOU in place to assign billing rights to the lead LEA. That's the formal definition. You may want that agreement to include additional details such as redistribution of funds, roles and responsibilities, coordinating with the billing vendor if the consortium chooses to use one. There are other ways groups of LEAs can share the administrative effort of program participation, either as part of a formal consortium or outside of a formal consortium. Some examples here might include a COE or a lead LEA facilitating one contract with a billing vendor that all partner LEAs use. One LEA has a staff person who's responsible for following up on assigned RMTS moments for all practitioners in all the LEAs, sharing the training and coordination of documentation responsibilities, a central fiscal person that supports gathering financial information for completing the cost report. These are kind of informal ways that you could support each other. Now, this is kind of the important part because we're covering this in a very limited way, but next month we'll be hosting an entire workshop on setting up and participating in a billing consortium. And we're dropping, do we have the link in the chat for that registration? Great. So please register for that. And we will be getting, that's the whole workshop. So we'll be getting in a lot of detail, including a guest speaker who currently is running a consortium. So hope to see you there if this topic interests you. Next slide, please. So contracted services. For many small and rural LEAs, you may rely on your COE or SELPA to deliver services to students because you might not have enough students to directly employ staff. I saw a question earlier, and I hope this answers that question in the chat. If you're paying for these services from your COE or SELPA, then you have a cost, which you can include on your cost report and be reimbursed for that. Another question for all types of contracted services is if are the contractors billing for those services? If they're not billing, then you should be billing. You will need language in your MOU or contract to clarify who is doing the billing to make sure Medi-Cal is not paying twice. DHCS did a training in November explaining how to include contractor costs in this program. Those slides will also be posted soon to the website, and we're going to drop a link again in the chat for that. The main takeaway from this is if you're paying for contractor services, be it through a COE, a SELPA, or a third party, that's a cost that you can include in your program. And we gave an example of how that math works on a previous slide. There's also a link to a PPL, which provides guidance on contractor costs, and we'll put that in there as well. Thank you. Next slide, please. Let's talk about what it means to be a part-time coordinator. If you're a smaller LEA, you're unlikely to have a need for a full-time position devoted to administering the program. Instead, you may have someone that works part-time or can make this part of their other duties. Even though this may not be a full-time position, it's still important to have a coordinator to manage the program. It's not uncommon for this to be a community school manager, a director of special ed, assistant superintendent, with some possible help from support staff. As this is specialized knowledge, it's best practice to have a backup or other staff that assist in parts of the program. In case of turnover, this may help keep the program running. It may also be possible to use a billing vendor to support in the administration, tracking of deadlines, and training of staff. But remember, LEAs are always financially responsible for the program, even when using a billing vendor. And I'll turn it back over to Lisa on the next slide. Thank you.
Thank you so much, Jeremy. That was an incredible amount of information. We acknowledge lots of good questions coming in through the chat, which we will get to momentarily. We first have a poll with some quiz questions. Again, we'll be getting to your questions shortly, so please make sure you drop your questions in the chat. And before we move into the Q&A, we're going to take a couple moments to answer the quiz questions that will pop up as a poll. And these are here to help us gauge how effective and useful this information that we presented today is. So the questions that have come up as a poll are: 1, true or false, telehealth can be used only for speech and occupational therapy services. Question number 2 is: what is a benefit of participating in LEA BOP? And question 3, what is one reason a small and or rural LEA would join a billing consortium? So we're going to leave those that poll open for 1 or 2 minutes. So please really quickly respond to those quiz questions as they are open. All right, I'm going to end the poll. Next slide, please. We'll just go through those answers to these questions really quickly. So again, quiz question number 1 was: true or false, telehealth can be used for only speech and occupational therapy services? The answer was B, false. And it looks like 90% of you all got the answer correct. Good job. As always, telehealth can be used when appropriately for more than just speech and occupational services. Next slide. So question 2 was: what is a benefit of participating in the LEA billing option question? 78% of you got the answer correct, which was C. It's a way to generate reimbursement for some health services to students. Again, as mentioned on slide 7, LEA BOP is an optional program for LEAs to recoup some expenses for providing covered health services for students enrolled in Medi-Cal. Next slide. All right, quiz question number 3 was: why would a small and or rural LEA join a billing consortium? And 82% of you got the answer correct, which was B. It is to reduce the administrative effort of participating in LEA BOP. So again, as Jeremy covered, and we will do a whole training on it in January, a billing consortium is a group of LEAs that submit one cost report and bill under a single NPI, National Provider Identification Number. And the goal of a consortia is to reduce the administrative burden for participating LEAs. So nice. Good job, everyone. Thank you so much for responding to those quiz questions. And now we'll get to your questions. Next slide. So we were going to respond to registration questions first, but we only have about 10 minutes for questions and answers. So we are going to move to questions that were received via the chat. We'll try to get to as many questions that have come in through the chat, but please note, if we do not get to the question you asked, all questions will be responded via email after this training. Okay, so I'm going to have my colleague Lydia and Jeremy join me, who will help us answer some of the questions. So the first question, which I think was regarding to the payment cycle, is does it add steps to the timeline of participation if an LEA works with a third party, a billing vendor like SACE Billing?
Hi, everyone. So billing vendors do not necessarily add to the timeline. Many LEAs have contracts with vendors to submit claims to Medi-Cal on a regular basis. Some LEAs also use their billing vendors to help complete the annual cost report, but it doesn't necessarily affect the timeline.
Great. Lydia, if you bear with me, can we answer one of the questions that was received via registration that is related to this, which is it required for an LEA to hire and work with a billing vendor?
Hiring a billing vendor is not a requirement and is completely up to the discretion of the individual LEA. However, again, some LEAs and districts have found vendors beneficial in alleviating the administrative burden of the program. DHCS does not recommend a billing vendor, but you can always talk to LEAs in your area and get a better idea of their experiences. For more information, please see the Relaunching Your LEA BOP workshop, which discusses this topic in more depth. I believe we might have dropped a link in the chat earlier, but I'll just drop another link now to make it easier to access.
Thank you. Next question we received via the chat was, how often is the final settlement a debit where the LEA owes money back to the state versus a credit where the LEA receives money from the state?
Can you repeat that one?
Yeah, sure. So the next question is, how often is the final settlement after the cost report is audited? How much is it a debit where the LEA owes money back to the state versus a credit where the LEA receives money from the state?
Oh, so that's interesting. I think those actual statistics, if you're looking from a statistical point of view, are actually forthcoming. I think the DHCS is tracking that now. But if you're looking from a kind of math point of view, it has to do with going back to that slide with the allowable cost and all the different discounts. If you have very low cost and very low MER, then your final settlement is going to be lower based on that math. And if during that same amount of time you build a lot of interim services, that's the day-to-day submitting of claims, then you would have a debit. My opinion is that under the new system as it currently stands, it's less frequent there's a debit compared to the old system. And that's why we spent, I think we had 3 different slides kind of laying that out, how the math works with the allowable cost and then the MER and the FMAP and the DMSP, because I think you can kind of plug in your own numbers and get an idea now, where before it was a little bit harder.
Thank you, Jeremy. Lydia, was there anything you wanted to add to that answer? Okay, great.
No, I'm set. Thank you.
Yeah. I'm going to move us down to one of the questions we got. We got a couple of questions about contracted costs. So I'm going to read a couple of them that we got. I think the answer is pretty much the same for all of them. So one question was, as a small district, we contract with the County Office of Ed for our nurse plans. Are districts allowed, is your small district allowed to bill for that contracted cost? Again, similarly, if we contract with the COE for such services, can we still get reimbursed? And then if we contract out for related providers, can we still get reimbursement for their services?
So for these questions, this would depend on the billing rights that you have assigned through the MOU that you have with the district. If the LEA has an MOU where they pay the COE for these services, the LEA can bill for the services and include the contractor costs on the CRCS. We recently had a workshop on including contractors in your program. It will be available soon on the training page of the LEA BOP website and will be shared via an e-blast.
Awesome, thank you. What does, the next question is, does the IHSP coverage include non-IEP services such as on a 504 plan? Yes. So let me ask the question again. So does the IHSP cover non-IEP services such as on a 504 plan?
The IHSP is an umbrella term for many types of formal care plans, including 504 plans, a nursing plan, a healthcare plan, etc.
And in the example of the question, if your LEA uses 504 plans, that is considered a type of IHSP, and yes, does not include IEP services on it. I think we're gonna, okay, a couple more questions, 1 or 2 more questions I think we'll have time for. And again, if we don't get to your question, they'll all be responded to in writing after the webinar. The next question is, what is the difference between LEA BOP and ESMA? And ESMA stands for, oh, maybe you can answer that. School-based Medi-Cal administrative activities is what ESMA stands for. So what's the difference between those 2 programs?
So the LEA BOP provides reimbursement related to direct health services rendered to students, like um, therapy sessions provided by an OT or SLPs and assessments provided by many health practitioners, whereas SMA program covers administrative activities such as outreach and referral activities and linking potentially eligible students and their families to Medi-Cal, stuff of that nature. So direct healthcare services and administrative services.
Thank you. We got this question, which I think was answered after the person asked this question, but I think it's worth reiterating the answer. But the question is, where do we find the Medi-Cal eligibility ratio?
When an LEA participates in the LEA BOP, there is a training on how to calculate the Medi-Cal eligibility ratio, actually. Basically, there's a snapshot date that DHCS will provide the LEAs, and on that date, you'll pull your LEA's total student enrollment account. Then you'll submit the total enrollment account through a process called the data match eligibility process to determine how many of your total students are enrolled in Medi-Cal as of a certain point in time, that snapshot point in time, and the eligibility to receive federal match funding.
When your LEA decides to participate, DHCS will walk you through how to find your Medi-Cal eligibility ratio. And if an LEA is not currently enrolled, one of the things that Jeremy presented on is you can use your free and reduced price meal per session as a very rough proxy for that. So you can get a sense of what your LEA might see in terms of Medi-Cal eligibility ratio. Now, again, those are different forms. It's a different eligibility process, a different enrollment process for both of those too. So please use it with a strong dose of salt, grains of salt. But it can be usable. Both free and reduced price meals and Medi-Cal eligibility and enrollment is based on income status. So that's why we suggest that as a proxy. I think this is going to be our last question. And again, I apologize if we're not getting to all your wonderful, wonderful questions. Lots of really, really good ones. Is there a list of telehealth providers available to contract with? Kind of very similar to the billing vendor question that came up earlier.
No, DHCS does not maintain a list of telehealth providers that LEAs could contact with to deliver services to students. However, many healthcare practitioners provide telehealth services, and you may want to check with current contractors to determine if they have this capability.
That's a great tip. Thank you. All right. Thank you so much for those wonderful questions from the chat. Lydia, thank you so much for those answers. Again, if we have not gotten to your question, we will respond to questions in writing after today's webinar. Now, Colleen, can you advance to the next steps and closing? Great. And this brings us to the wrap up for today's workshop. I don't know about you, it felt very fast, but we will leave you with some next steps that you can take. Next slide. So these are resources where you can find support. So we've shared a number of resources today that are specific to how you can successfully participate in LEA BOP as a small or rural LEA. And there are other general resources that your LEA can access to find support in all other aspects of administering the LEA BOP. So we encourage you all to spend time on the LEA BOP website and reach out to DHCS for any questions you may have through the LEA inbox. Additionally, DHCS hosts quarterly stakeholder meetings. Information about those meetings is available online from past meetings, and then we're dropping a link to where you can find the meeting information in the chat as well. And the best way to know about those meetings and when they're happening is to sign up for the email subscription list. And we are also dropping a link. If you have not already signed up for emails from the program, please do so. And then the last support, we also encourage you to sign up for technical assistance with DHCS. and we're including a link to the technical assistant site visit request form in the chat as well. That can be a great way to get some of your particular questions answered. Next slide. All right, so we have some upcoming workshops and trainings. We have 2 more workshops that we are hosting in partnership with DHCS. Next month on January 16th at 9 a.m., we will have a workshop on LEA BOP support, how to start and participate in a billing consortium. So registration is now open for that, and we will drop the link again in the chat for where you can register. And then on February 15th, we will have a workshop for LEA BOP, new LEA BOP billing coordinators. So those of you that are responsible for managing and supporting this program for your LEA, and that will be on February 15th. We hope you'll join us for for one or both of these upcoming trainings. Next slide. We are almost at 2 o'clock. Thank you everyone for participating in today's workshop. We hope you enjoyed it. We hope you learned something today. We hope it inspired you to look into participating in LEA BOP or looking at your current program and seeing about opportunities to expand your billing or expand your participation. Your feedback is incredibly important to us. It helps inform how we develop future trainings like this. So we really encourage you to take a moment to take our feedback survey and share with us some of your feedback from today's workshop. You can use the QR code on your screen, or we will be dropping a link directly to that survey in the chat where you can submit your thoughts. And again, thank you so much for participation, for your great questions, and we look forward to seeing you again soon at another workshop. I hope you have a great end of 2023. We'll see you next year. Thank you.